Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to start by thanking Dr. Muhammad and the organizing committee for the kind invitation to be here. Again, I was in the first meeting in 2019, and it's a great pleasure to be here and to see all the progress that happened over the past few years. Really remarkable work, and I really congratulate you for what have been achieved. Today, I'm going to present on the challenges that we have been facing with different pandemics globally as well as in Oman. My presentation will be on the impact of the newly emerging pathogens on the blood bank services. And I don't have any conflict of interest to disclose. So we know that all communities are at risk of developing different types of emergencies and disasters, and these are including those that are related to infectious disease outbreaks. And the reason behind this is the many challenges that happened worldwide, including climate challenges, unplanned urbanization, population growth and displacement, and antimicrobial resistance. All these do play an important role in increasing the risk of developing different outbreaks and pandemics. And this has the potential of impacting the blood supply because it does affect our donor recruitments and blood donation. It also tends to affect the donor eligibility criteria, depending on the pathogens that is impacting the nation, as well as it can affect our transfusion practices. And the management of these risks is very vital, and we all have learned a lot through COVID-19 pandemics, and it's very important for us to learn from these lessons in order to prepare for future outbreaks and pandemics. And this requires local, national, as well as global health security actions. Now, this is a recent systematic review that looked at the impact of different types of disasters on different blood banks and the blood supply. And you can see here that this review did include 98 studies over the past 30 years or so. And it really showed that most of the disasters that impacted the blood supply were actually pandemics. And 17 of these were related to natural disasters. And most of the studies that were related to pandemics and blood donations were published during the COVID-19 pandemic. With regards to natural disasters, 88% of the studies were related to earthquake type of disasters. What we have learned from this systematic review is that the reactions or the impact of these disasters on blood donation is different. So following COVID-19, for instance, the blood donation rate has decreased compared to the pre-pandemic period. In contrast to this, and we will talk a little bit more about this tomorrow, following earthquakes, the donation rates does increase. And this is basically reflect the difference in the donor behavior with different types of disasters. The other important highlight that this publication has shown is that none of the papers have discussed anything about preparedness plans to pandemics and the earthquake disasters. And this really highlights the importance of having an emergency plan in place in preparation for these types of disasters. Now, you could see here that 55% of these publications describe the decrease in the blood donation rate, and this did impact different countries regardless of their bank classification. So this included low middle income countries as well as high economic countries. So the impact is universal. And this is basically reflect the fact that this is all related to donor behavior and reactions to the disaster rather than the blood services preparedness. So let's move on to speak a little bit more about COVID-19. COVID-19 is the deadliest pandemic that has hit the world on the 20th century. It has resulted in a historic public health crisis that impacted all different fields, including the healthcare system, and it also affected the blood supply and the transfusion services. However, COVID-19 have taught us, and it is really a model that we should really learn from in order to prepare ourselves for future disasters and outbreaks. Now, the thing that impacted the blood supply is the donor affair, and this is an expert review that I had the pleasure to be part of, whereby we looked into the different factors that impacted the blood supply during COVID-19 pandemics. Donor fear was the main reason why donation have declined during the pandemics. In addition to that, there is cancellation of blood drives, there's social distances practices that took place, there was lockdown that affected the donors to reach to the blood donation centers, and there were new donor eligibility requirements. And if you remember throughout the pandemics, the WHO kept changing these donor criteria with every single update to its recommendations. And some of this criteria was related to the infection, and some of it was related later on to the vaccination. So you could see how dynamically we can defer donors and treat them differently, which can impact the blood supply system. When it comes to the Eastern Mediterranean region, if we think back, January 2020, the first report of COVID-19 happened in the United Arab Emirates. Very fast after that, we had impact on different types of countries. And by April, the last country in the region has reported COVID. And you can see here the very fast increase in the number of cases in the region. And unfortunately, as you could see, many of the countries that we have in the region are also classified as low or upper, even middle income countries. And that does impact reporting, testing, availability of vaccinations, and so forth. So with collaboration with my colleagues from the region, we did work on this publication that was considered as one of the biggest success of collaboration and research that we had during the pandemic. And this was one of the fastest publications that we released to reflect the challenges that we had in the region with regards to blood supply. And it is considered as one of the highest that has been cited during the pandemic with regards to impact on blood donation. And you could see here that 16 countries from the region, including 10 LMICs, contributed to this paper. What we did contribute here is lessons that we learned, what actions we did during COVID-19 pandemics, and what recommendations should we put in place for the future. And you can see here the different actions that we as countries have acted very quickly in response to the pandemic. Quite strikingly, most of the countries have collaborated with military as well as governmental institutions in order to continue the blood supply. And this is very different, it's very unique to the region, and we don't see it in other regions. The other thing that we could basically worked on is home collection, and this is something that countries like Saudi Arabia have basically worked on, as well as others in the region. And we did report activation of contingency plans. So many of our countries did have activation of the contingency plan, but we also learned from each other that these contingency plans did require some sort of modifications after what we learned from COVID-19. The other thing that we listed in this paper, and I recommend you to read it, is the number of lessons that we learned. And these are a very long list, as you can see here, on donor mobilization, communication with the public, donor and safety of the staff, how do we manage the blood stock, the staff management, reagents, and disasters and contingency plan. It's a long list. If I focus only on blood donation, the things that we learned is to be proactive in communicating with the public. This is a very important key message. When we remember back COVID, the thing is the influence of the media on us as healthcare providers as well as donors and society. The amount of fear that we had at a time whereby initially we didn't even have enough masks, people did not know how this virus can impact our healthcare. Donors were having fears on what is the conditions, how can we protect them when they come to donate blood in our centers. So being proactive was a key thing. We had to be there in front of the TV and the media up front, even while we did not have enough information of how safe we can be in order to ensure that the blood supply can continue for our patients. We had to use social media channels. We did use public figures. We were fortunate in the university hospital that we had an ambassador program for our blood bank, and this is the program that we utilized in order to spread the message to the public that we need to have blood donors. And we had to gain public confidence for them to come in. And this had to be in different languages, and this is something we learned during COVID. You should not only target your messages only to the Arabic-speaking donors, but you should do that in different languages, depending on your society. And you should have a hotline to address concerns of the donors. The other thing that we learned is that we had to mobilize hospital staff very early to blood donation, before they get exposed to patients, before they get vaccination, so that we can at least ensure that there is a bag of blood that was donated and it is in our stock before they become infected or exposed or vaccinated. To utilize spacious community centers such as a sport hall was very important. And I know that there is a center or a country that have actually moved the whole blood donation area to a tent or to a sport hall in order to ensure that there is enough social distancing between donors. And this basically taught us that we have to really find out ways in order to ensure safety of our donors. We needed to assess regularly what is the governmental decisions when it comes to lockdown. So if you remember, initially, there were times that were defined. These times could be adjusted. This adjustment happens very quickly, and we are just at the back of the end listening to all these directions, and then reflectively telling the donors when to come and when not to come. It's very important to be upfront and to speak to those decision makers on how these decisions are impacting you and how you should basically be in line with them with the decisions to direct the donors on how to reach out to you. And it's very important to have that open communication with the higher authorities. And then the other thing is that you can collect blood from other cities that are not affected with outbreaks or pandemics, and this is something that can be considered. Following this publication, I worked with the ISBT on an international assessment on the impact of the blood supply, of COVID on the blood supply on an international scale. We published this paper in Vox Sanguinis. You can see here that it included 42 country representations, including 24 low and middle income countries. In this survey, similar to our region, 70 to 76% of countries did report decreased donation and blood shortages, mainly because of the donor affair. So it's universal. Patients' populations, however, were broadly affected differently between countries, and the main countries that did report impact on the blood donation supply on patients are countries that had high rates of patients with hemoglobinopathies. And this includes our countries, for instance, like many countries of the regions did report the same. And so the important message here is that the impact itself can be different depending on your own patient's population. Some countries did have cancellations of surgeries. It didn't impact their transfusion rates, but other countries where there was a high rate of hemoglobinopathies as well as hematological disorders, there was an impact on their patients. And we also listed in lessons related to operations, protocols, resources, communications, and how to collaborate better. And this is basically was put in the middle of the pandemic as a way for us to try and prepare better for the future. The other challenge that we had during COVID is the collection of convalescent plasma. We know that convalescent plasma was derived from recovered COVID patients, and during the pandemic, the immediate need for convalescent plasma came up very early. And at that time, we didn't know what is the safety of convalescent plasma, how it is collected, how do we test it, and how do we prepare it. And there was no universal protocol at that time, but everyone was trying to collect convalescent plasma at the time where they were challenged also with the blood supply. We know with time very quickly that CCP is safe. Convalescent plasma is being reported not to be different than standard plasma in terms of risks. There is no data to say that COVID-19 can be converted or can be transmitted through blood. However, the commonest side effects that can be seen are really plasma-related, like TACO and TRALI. And there is no evidence on what is the proper dosing, what is the effectiveness, and very limited data was available for us, mainly because of the type of the trials that were happening or the studies that were happening predominantly were observational in nature. This is the largest data that came up early in the pandemic from the Mayo Clinic. They reported the safety of using convalescent plasma. It had a less than 1% rate of serious adverse events and 13% risk of developing of death and mortality. And you could see that most of these are really related to side effects like trali and TACO. And these death cases were mainly seen in critically sick patients, whether they are in the ICU or they are mechanically ventilated. But then, right, CCP is safe, but then how efficient? Should we divert our forces and blood banks and transfusion services in collecting CCP, or should we focus on blood supply? And we really need to think about this for future pandemics, if we will live to that time or we'll see another one. This is a Cochrane review that is really undergoing a process of activation and updates very frequently. This is the latest review of this Cochrane systematic review from 2023. It did include 33 randomized controlled trials, predominantly looking at patients with moderate to severe COVID-19. And this Cochrane review did show to us that there is no benefit for using CCP in the treatment of patients with moderate or severe COVID-19. It does not impact on mortality. It does not impact on the rates of invasive ventilation or faster discharge from hospital. But there was a very low to a low certainty of evidence in treating patients with mild COVID-19, and there are 49 other studies that are still ongoing, which we are waiting for in order to close this question, whether if we should be collecting CCP for the future or not. We did another study looking at early use of CCP. Should I use CCP really early, even pre-hospital, before the patient gets admitted while they're still having a mild disease? This is the work that is also done through the ISBT clinical CCP working group. And we did look at the different studies that were reported at that time. Out of the studies that we had, there were 2 studies that did report a potential benefit of early administration of CCP. Prior to hospitalization to prevent severe disease. However, still we are not quite clear from the data that we have whether if it is needed, and that's because of the heterogeneity of these studies. These studies did include different time frame of administration, different patient population, different titers that were used for testing, and you could see here that the controls were even different. So we really need robust data to tell us whether if in the future a pandemic happens, should we collect CCP or not, and how we can have that within our healthcare preparedness plan for any future pandemics. So early in the pandemic, and I remember this paper, this is the first out of the 10 publications that we had at that time. We had this paper to think about what are the gaps in collection of CCP that we need to fill in, hopefully during the COVID-19 pandemic, with required recommendations for future studies. And I looked at this paper and I thought, okay, how much of this we have covered as medicine, as a medical professionals or even researchers in the field of COVID-19. The points to consider that we had at that time is the following. When we collect CCP, wherever possible, it has to be collected within the context of a clinical trial until or unless its efficiency and safety are established. And we could see that this happened with time. We started with observational studies. It also happened in some countries on conventional use, but then later on there were more clinical trials, as you can see in the latest update of the Cochrane review, that included the use of CCP within a research setting. If CCP is used outside a clinical trial, data should be collected to gather experience and outcome. And we did have that also been reported. Minimal effective dose and whether it is related to specific neutralizing antibody titer is currently unknown, and we required more studies in order to tell us what is this dose, and this is still a question to be answered. All patients should receive the best available supportive care as soon as being appropriate and available, and this has been happening. We also recommended that effectiveness of CCP be compared to other treatment alternatives, and this has been addressed in the Cochrane review in comparison to hyperimmunoglobulin, and they found that there is no difference really in the efficiency between CCP and hyperimmunoglobulin. So that partially is covered. However, we need more data in comparison to antiviral agents. And finally, we have to monitor patients for adverse events while on treatment to know the safety of it, and we have that data available. And we need to define the eligibility criteria for the use of CCP in adults as well as in pediatrics and neonates, and that's a question that is yet to be answered. So in Oman, while we had a question of dengue. And this is something that was very interesting. It was kind of an outbreak that really happened, but basically brought me to think about dengue as another pathogen that we need to think about in blood banks. So dengue is a viral infection that is caused by a dengue virus that is transmitted to humans through the bite of infected female Aedes aegypti and Aedes albopicus mosquitoes. It is found in tropicals and subtropical climates worldwide, mostly in urban and semi-urban countries and cities. And there are 4 different serotypes that are classified, as you can see in this picture. Now, prior to the 1940s, dengue was characterized by epidemics that occurred relatively infrequently. However, it has been very rapidly spreading throughout the world. And you can see here that it has grown by about 8-fold from the 2000s. And the reasons behind this is multifactorial. One part of it is globalization, so that basically induced a rapid urbanization movement of populations between different countries, as well as the climate change. And that basically have led into the increased spread of dengue to include different type of, or different countries, or to involve other countries. And in the 1970s in particular, airplanes became the principal mode of travel, and that helps in the transmission of the vector to different countries. So why do we speak about dengue here? Is because dengue is transfusion transmitted. The human-to-human transmission of this infection happens through the vector, so you do need to have the vector. But however, there are rates, or there are very rare reports of it being transmitted through blood transfusion, or it can be transmitted through other means. And this appears to be very rare, but it can happen. How it impacts the blood donation and the blood supply is that most of the patients with dengue, similar to COVID early on, they have mild disease, and so they can be asymptomatic by the time they come to donate blood to you. And this is how dengue is transmission. So if you have infection with dengue, it does not prevent the infection with other serotypes of dengue. In fact, one serotype infection can increase the chance of developing a more severe disease with the other serotypes. And the mosquito itself, as long as the vector is available and there are climates that are allowing this vector to populate, and that can help in the transmission of the virus to human beings. And as I said, most of the infections are asymptomatic and mild, and they can be self-managed. But however, severe dengue can be fatal, and it can lead to hemorrhagic fever as well as dengue shock syndrome. So how does this impact the blood supply? And why is it important for us to think about this? Is because dengue is one of these viruses that does spread worldwide. And the epidemiology of it is still not very clear, developed in different countries. And it does impact donor deferral. And that can impact donor deferral due to infection or due to even exposure to someone who had dengue. And the risk of transmission from an asymptomatic viremic patient is potentially possible because those donors can be asymptomatic by the time they donate blood. And it can induce, of course, increase in the demand of the platelets and the plasma if someone developed a hemorrhagic density. So it can have an impact on the transfusion services as well. So if there is a dengue outbreak, what are the different mitigation strategies? One is donor deferral. Those include those who have history of dengue or history of fever or history of travel to a dengue area. You could have the donors to report if they have any symptoms of infection or any similar types of infection. You could do donor testing, and that can include NAT testing. You could implement pathogen reduction technology, but that can be limited in effect to a certain components like your plasma, but not to all other components. You could do proactively public awareness to raise the importance of reporting any manifestations of dengue or visiting an area that is endemic with dengue. So how do you select your mitigation strategy? It depends on the epidemiology of the virus in the country. It depends on the cost that you are looking at. And it also depends on your population. So if the epidemiology of the virus in the country or the geographical area appears to be low and it is unknown, the prevalence of the dengue infection in this donor population will still be unknown, and therefore there might be a risk of viremic donations in the blood supply. If you have that low donor prevalence or dengue prevalence, then you might be okay with just donor deferral because it's going to impact a very small percentage of your donors. However, if you have a low overall prevalence but regular seasonal outbreaks of dengue, then you might consider testing in these outbreaks. So the mitigation strategies for donors, importantly, does include all donors that are infected, all donors who were exposed to someone who's infected, any donor with history of recent travel to an area that is infected, and so forth. And the problem with donor history is that it has a very low sensitivity and specificity. A donor might have, or may live in an area that doesn't have dengue, but they basically can go and work in an area or in a city that has dengue and come back their home. They are potentially exposed in their office area, or if they go to a certain area for shopping that is known to have dengue, they are potentially exposed. So area of residence by itself is doesn't have a good sensitivity in order to help you with deferring these donors. And so for how long do you defer? So it depends on different recommendations. This is what is used in different countries. They basically recommend to defer for a maximum of twice of the incubation period. So incubation period is about 7 days, as I shown in a previous slide. So that will be a minimum of 14 days deferral for any donor who is exposed or infected or has traveled to an area that have been having any dengue. What about testing? So there are different ways whereby you can test for dengue, including serology. However, antibody and antigen-based testing is really lacking the required sensitivity for detecting an acute infection. It can also overlap with the other serotypes. It can also overlap with the positivity with the other flaviviruses. And if you have a viremic donation, it can potentially test negative initially. So the RNA testing or NAT testing is basically considered as a methodology of choice if you would like to screen for dengue. So what happened in Oman? First of all, we don't have dengue. We are a hot country. It rarely rains in Oman. We don't see a lot of rain. And most of the cases that we have in the country were actually travel-related dengue from nearby countries, including predominantly India, Pakistan, Malaysia, sometimes Yemen, and Saudi Arabia. So most of these cases are actually travel-related, and this has been the trend in the past since the 2000s, according to our epidemiological data. And most of the cases that were reported were also in non-Omanis. And so you can see here that the number of these cases are quite very low. And the cases were mainly reported from Muscat government, Dhofar, and North Batna. And these are the most heavily populated areas and governments in the country. However, in the 2nd of December 2008, we had the first reports of potential endogenous dengue. What I mean by endogenous dengue is someone who is Omani or lives in Oman, haven't had any history of travel, but was confirmed to have dengue. And all these 3 cases were from El Sib district in Muscat government, and the genotype for this was dengue 2. So how did this, first of all, it had to be reported to WHO. WHO put this as an alarm that we have reports of dengue in Oman. But then the government have worked very hard in order to have vector control, and it really had succeeded in that in January 2019. So out of all the cases that were suspected, there were 122 that were confirmed, 21% had confirmed, 24 cases were hospitalized, and there were no deaths were reported, and there were no cases that were reported after March 2019. So it was very well controlled by the vector controlled measures. And you can see here that all these cases that were reported were from El Sib area in Muscat, and that area is really known for being very close to the sea, and it has more farms in that area, and so it could be associated with higher breeding sites. And then we went through COVID pandemic, and then in 2022, we had another report of a dengue outbreak. So we barely recovered from COVID to go into this. This is the time whereby we had 2 different districts in Muscat governments. 250 suspected cases were reported in a period of 2 months. None of these cases had any history of travel. And half of the cases were hospitalized. 50% of these were Omanis. And you can see here that it did affect different donors or different patients of different age groups as well as gender. But it was very well-defined outbreaks from March up to April of 2022. And this is to show you where these areas of hypers have happened. This was in El Sib area and El Bosher area. So, and it is all up north in the northern part of Oman. So what happened for us as blood banks at that time? The Ministry of Health Blood Services actually have issued a new donor criteria for deferral of any donors that have any history of dengue for 6 months until they recover from dengue. Donor defer for 28 days if they are residing in an area that is affected by dengue or history of exposure. Donor defer for 28 days from the day of declaration of the end of the outbreak, so they continue. If they live in an area of an outbreak, you have to wait for another 28 days after the clear of the outbreak for them to be able to instate to the donor pool. And they recommended to implement NAT. And they actually, the Ministry of Health did implement NAT before the university, so they got NAT being implemented in that year. This is to show you where is Muscat is and where is El Sib area. So you can see here where El Sib, whereby these breeding sites or cases were reported. And this is where we are located as a blood bank. So you can see here that we are in a very close proximity to that. Not to say that we could get dengue, but most of our donors are from those areas. And the challenges that we faced as a blood bank is the increased percentage of deferrals that we had with this new policy. It did have also a negative impact of donor attendance. So donors did hear that there is a there's a dengue outbreak in El Sib, and therefore they thought that this implies all other areas in Muscat could not donate blood. It did had an issue of cancellation of our campaigns in the impacted areas, and those are the areas that are near to our blood bank, so it did impact our donation campaigns distribution. These reports of which areas of Muscat was affected by the dengue outbreaks were weekly reports that were coming to us from Ministry of Health, and according to that, we had to adjust our donor deferral criteria for every single area from there. And that resulted in 13% decrease in the blood donation. So what we decided at that time is that we had to implement NAT. Why? Because the epidemiology of the virus was not very clear. The reports that were coming to us were impacting our deferral criteria on a weekly basis. And potentially, although dengue itself is very rarely can be transmitted by blood donation, the impact of this happening until we know what is the epidemiology very clearly was impacting the way how we were working in the blood bank. So we managed to get NAT testing. And up till this day, we had only 7 cases that were reported to be positive among our donors. So it is really, really very rare. And it shows us that if you defer donors just by history, you're probably going to be okay, but just using the donor history screening and deferral. However, it does impact your operations in your blood bank. So we continue testing up to date. We are still going to surveillance the cases of dengue.
1 minute, please.
I'm finishing. And to tell you the truth, since last year, we haven't had any cases that were reported of dengue in the country. So the country also have gone through the process of vector control, and therefore the rates of dengue cases have markedly decreased, and we think that it has been eradicated. So we are thinking of stopping testing quite soon. So what I conclude from here is that the impact of different pathogens on how we work in blood banks. The COVID-19 pandemics had provided valuable lessons to blood supply and donor management. We have learned so many things from COVID pandemic, and it should be utilized in disaster preparedness plan for the future. We have to have a clear objective evaluation for CCP, because that impacts how we work also in our donor recruitment and in our donation. And dengue outbreak significantly does impact the blood supply really early on in the outbreak when there is no enough epidemiological data. And therefore, I think a country have to utilize different mitigation strategies in order to overcome the challenges that can be based in the blood banks with that. With that, I would like to conclude, and I welcome you to Oman. Thank you.